Good afternoon, everybody. My name is Greg Archel. I am the Department Administrator, Ohio State, and I'm going to be presenting to you the FY20 AAAEM benchmark survey data results. I'm doing this on behalf of the AAAEM benchmark committee, as well as Jim Shulin. Jim normally does this presentation, but Jim was unable to do this today, so he asked me to step in for him. He did put together the slide deck, so I will give him all the credit and hope I do him justice here by presenting this to you. So I have no disclosures. So moving right into the data here. So COVID-19 obviously has had an impact on everybody. So the way we're looking at our FY20 information, it's a transition year. Basically, first 8.5 months of the year were normal. We had normal volumes. The data looked normal. It was actually increasing. Our visits were increasing from the previous year. And then obviously COVID hit. So mid-March through June, the last 3.5 months, data looks a lot different. So we kind of have a mix for our data results, combining normal 8.5 months and 3.5 months with COVID impact. And then even more of a transition we are in this year, we will have 12 months of COVID impacted data. So it'll be interesting to see when we collect this data in the fall, what it looks like. For those of you who haven't seen this presentation before, we've been doing this survey. We actually started like in 2010. We cover all three of the missions. So today I'm just going to barely touch on the teaching. Not going to cover research because that could be a presentation in itself, especially when we only have 20 minutes here to cover. So the most of it will be the clinical operations data. So normally we do one survey, capture all the data, and then present it. This past year, though, because of COVID, we actually did a special COVID survey, presented that to the chairs in January, and then they asked us to do a follow-up survey. So we actually did 2 special COVID surveys, and I'll be presenting some of that data here. And as usual, if you're interested in looking at this data, there's a portal that we work with Roundtable Analytics, and either your administrator or chair can help you access that data if you're interested in seeing any more of this in depth. For a start, this is the benchmark committee. We have about 24 members, both chairs and department administrators, and do a lot of work. We have monthly calls. Some months we even have more than one call. Really look at this data in depth to make sure our definitions are right, and try to make sure we do the best job we can collecting this data. So to get right into it, here's our data set demographics. So we were a little worried about this year collecting data with COVID going on. We knew everyone was really busy and everyone's time was taken up by dealing with that. But we actually ended up with 90, which was only one off of last year. So we were very happy to see that still people send in their data, and we kind of kept close to the same number we had last year. As far as geographically, same distribution we normally have, heaviest in the Northeast. But when you look at this data coming in, again, the impact of COVID, this group saw 700,000 fewer visits, 125,000 fewer hospitalizations, and $32 million less in collections. So obviously COVID impacted big time with us. Again, just looking at the data set, 57% are private. Most of us are level 1 trauma centers. So every year, Jim shows what's a typical academic ED. So in fiscal year 19, 64,326 visits. So if you compare that to fiscal year 20, again, a little bit of the blended COVID impact. So you can see the visits went down to 59,000. Interestingly enough, though, admissions, almost the same, OBS, almost the same. The big change was in our treated and released visits. So this whole pretty much 7.6% reduction is basically due to the treated and release volume going down. EMS arrivals, the number went down, but again, the percentage was consistent with what it had been in the past. So basically, it's again, all volume driven. But the big change for those who have dedicated pediatric departments had a big change there, almost 12% for the whole year. And at the high point of the COVID impact, it was close to 70% reduction in visits. So looking at our trend of visits throughout the year, the blue line here is total visits. So as you can see, we had been declining over the last couple of years. And if we had not had the COVID impact, we would have probably had an increase of approximately 3,000 patients. But obviously COVID did hit, and as you can see, we dropped off and went the other way. So another year of declining visits. And if you look again, missions were steady. It's all in treatment released population. So what's this current year going to look like? So we have, like I said, we had this COVID data that is on this year, this fiscal year's data. And if we project that out for the whole year, looks like our volume will go up in FY21 compared to FY20. So the COVID survey we did, we basically sent it out and we collected data from January through July of 2020. And the reason we started July, we wanted to see what the data looked like pre-COVID and then what happened during COVID and then during recovery. So we sent this out in January. We were 6531 visits per month, and you can see at the high point of COVID is down to 3504, which was a 46% decrease. And in July we bounced back up to 5333, so capturing about 82% of the pre-COVID volume. So splitting out discharges and hospitalizations again, discharges, they fell by 50%, and they have increased, or I'm sorry, they rebounded to about 79% of the pre-COVID numbers. Admissions fell 30%, and they have bounced back in July to 93% of the pre-COVID numbers. So as far as the pattern of decrease in visits, if you look at the 4 regions here we track, pattern's almost exactly the same. Timing may be a little different, but same dip and the same rebound. So what a lot of people have been saying, well, we're seeing sicker patients now in the EDs. In reality, if you look at the ratio of level 1 and 2 patients to level 4 and 5, the ratio has changed. We are seeing a higher percentage of level 1 and level 2 patients. However, this isn't due to us getting more level 1 and level 2s. Again, it's because the level 4 and 5 patients have decreased. So when you do the ratio, we are seeing a higher ratio of 1 and 2s in the department, but not a higher number. So we presented that data and a little more to the chairs in January, and they asked us to go back and do a follow-up and see, well, what has happened since July. So again, the original survey, we had about 40 institutions respond, and the second survey, I think we had in the low 20s. So this kind of shows what's happened since July. We collected the data up through February. So again, you can see we're at 6531, 3504, 533, and then we kind of fell back in February to 4606. So if we look at this on a patient per day basis, it was 211 pre-COVID, 117 at the height, 172 in July when we the last data point we collected in the first survey, and now it was a 165 in February. Not sure where it lands now. I think just anecdotally talking to some people, and I know here our volumes have been creeping up again a little bit. Again, probably not to where we were here, but maybe closer to here. So again, that was a 46% reduction overall, rebounded to 82, and again, in February is about a 78% of the pre-COVID numbers. So if we look at just the 12 months when COVID started, our volume, our census would have been 58,754 visits. So if you just look at hospitalized patients, again, the bounce back, 30% reduction went to 93, and it's kind of stayed consistent through February. But if you look at the discharge patients, again, they had the 50% reduction originally, 78% in July rebound, and now it's fallen off again a little bit, down to 72%. So again, if you just want to look at blue line here is 2019, same months shown in red in 2020. So you can see then the amount of patients we were down each month, with obviously April being the biggest impacted month. So 7965 fewer visits and 318,000 less in the survey population. So we also pulled the data again with this COVID survey, looking at, so what percent of our patients actually were positive for COVID? So we all know the impact this whole pandemic has had on our operations. But it's interesting to look, obviously we don't have the PUI number here, which we know is big. But if you look at the actual patients who tested positive for COVID, it's only 3.5% of our visits. And at the peak in April, it was 7.2%. So 3.5% of our visits caused a big disruption and change, obviously, to our operations. So enough with the COVID survey. If we look at our normal data that we usually present, one thing we look at is our length of stay. So if you look at our length of stay since 2016, it is creeping up. And if you look at our discharge length of stay, it's staying fairly consistent. The big change is in admissions. So we have almost, 7/10 of an hour change in median length of stay since 2016. So why is that? So if we look at what we think is most under our control, right, which is bed to decision, so time the patient gets into bed till you make a decision what you're going to do with at disposition. For discharged patients, it's stayed pretty consistent in the last 3 years. Admitted patients, it's almost exactly the same number. So if this time under our control has stayed consistent, but the length of stay is going up, it's pretty obvious what the answer is. It's boarding time. So if we look at boarding time, and again, we define boarding time as from the moment the decision has been made to the patient gets out of the department. The median time has stayed fairly consistent over the years, but if you look at the mean, it has shot up by almost an hour. So if the median is staying pretty consistent, but the mean's going up, it means that right-hand sided tail is growing, right? But this is interesting. We still had an increase last year, but when COVID hit, boarding went down. We had a 66% reduction in April and a 33% in July. So even though the boarding hours went down because of COVID, we still had an increase last year. So if we look at why, this is again going back to 14, these are patients who board less than 4 hours. As you can see, it has been decreasing, going from roughly 75% down to just over 60% last year. Patients here 4 to 8 hours, pretty consistent, 16% to 17%, not much of a change. But population that's boarded and stays in the ED greater than 8 hours, as you can see in 14, it was 7%, and now it's up to 16.1%. So this increase in boarding time has caused that length of stay to creep up. So these patients that are boarded, who cares for them? So we've been asking who does care for them. So 67% report that inpatient teams come down and care for the non-ICU patients. So this has been increasing each year. And 40.5% inpatient teams care for ICU patients. Interestingly enough, though, as far as hospital support, only 34% provide nursing support and 18% provide financial support for these boarders. As far as our ancillary utilization, no real changes. CT has been going up. The big one here, Jim likes to point out, is if you look at MRI turnaround time, median is 4 hours, but the mean is 7.2. So again, the outliers, ones to the right, are really the ones we feel the pain for when you go through and order an MRI. So we've been working on a complexity index. We're trying to get an acuity index for patients in the ED, not just for the patients we admit. And these were the kind of the 5 metrics we've kind of noticed when we've done statistical analysis that are kind of important to determine how sick or how our acuity of our patients are. So if you look at the hospitalization rate, high acuity pro-fees, and acuity level 1 and 2 ESI, they have been increasing since 2016. But interestingly enough, the EMS arrivals has stayed flat, and the admissions actually from ES has actually been going down. So this is something we're just in its infancy to try and develop. So we keep working on this, and hopefully more to come on developing this acuity index. But here's what it looks like graphically. So if you take all the data, and this again is going back from 14 because we have the data that far back, through 19, the dots show how each institution's score is. And if you look, we broke them up into our different types of EDs. So primary academic obviously is the highest, 0.655, and then you can see academic affiliate lower, and then the community hospitals. So more to come, hopefully, on our complexity index here as we develop it. As far as CMI of admitted patients, as you can see, these are the visiting hospitals, so no change year to year. Comparing us to other type of EDs, again, no change from year to year. Again, we're bigger, have a higher hospitalization rate, case mix index is higher, but we do have lower bed turns per year. And obviously this is probably because we're taking care of sicker patients and the boarding issue again. So Jim has come up with an idea looking at what he's called value-added time. Everyone knows the patient feels this total length of stay. That's what they feel. But out of that total time, what is value-added time, which is basically, again, the bed to decision time. So if you look at all the discharge patients, again, and it doesn't really matter which type of ED you're in, it's approximately 73% of their time is actually value-added time that gets them either being treated or getting some type of test or procedure done. If you do the same analysis for admitted patients, again, there is a little variation depending on type of ED, but again, it's 45 to 55% of their time. So again, patients feel this, but this is the percent of their time that is actually value added for them. So our throughput times, again, comparing them to different types of EDs, not much change from year to year, but again, the academic centers do have higher lengths of stays. Bed to decision, same thing, still a little bit higher. And again, part of this is probably because of our teaching times. As far as nursing care, hasn't really changed. These kind of show you the nursing hours per day, main ED, fast track, OBS, behavioral health, and triage. Again, not much change from year to year. Patient to nurse ratio, again, these didn't change much either. Pretty consistent across the board. As far as nursing coverage, we were concerned that does nursing really provide all the hours of support they do that they're budgeted for, and that it appears that they do. They're pretty close to 100%. But where they're falling off is in nursing support. Nursing support was pretty low last year, so we don't know if that was because of COVID and it cut back or exactly what happened. So it'll be interesting to keep our eye on this. As far as residency goes, the big change here we noticed was the number of 3-year programs actually dropped, which meant the number of 4 has increased. So it'll be interesting to see if that trend continues or if it stays consistent. And a little bit about collection data. Our charge data, again, stayed pretty consistent. The change here was collections per visit went up, which makes sense if we're seeing less low acuity patients. And the same way here, the percentage of billing coming in from E&M codes went up again, which would make sense because we're charging the higher level patients versus the lower level patients. As far as the trend over year to year, E&M codes, again, level 3s, pretty steep drop since 16, and level 5s in critical care, conversely, are going up. As far as payer mix goes, Medicare has been slowly creeping up, while Medicare is slowly going down. So again, something to keep our eye on. And with that, I'm done. I could take any questions. I'm pretty much at our 20-minute limit, but there's my contact information. And if anybody has any questions, feel free. I will answer whatever I can. And urge everybody to go hear Dr. Volturo's talk next.
There is a question in the chat if the slides are available for download.
Julie, do you know that answer?
The session is recorded and is available.
Yeah, if you email me, I could
demand.
send them. Yeah, if you email me too, I could send them to you.
And Greg, if you send them to the office here at education@sam.org, we can add them as a resource on the recording.
Oh, okay, we'll do that.
It looks like, thank you for the talk. It was very informative. It was really interesting to see the trends in those numbers. Are there any other last questions or comments from the audience?
Just a great presentation, Greg.
Thanks, sir. It's a lot of data to talk about in 20 minutes.
It is.
Yes. All right, well, thank you, everybody.
All right, thank you.